Vielen Dank, Kim.
Thank you so much, Kim. And we actually do have a lot of German questions, at least. I'd kick off by reading out the questions in German to you, and you'll get them translated by Sandra and Stephanie.
Eine Frage, wir haben eine Familie mit 2 Fragen. Ich würde da die erste Frage jetzt.
We have one family with 2 questions. Why don't I read out the first one? We have a daughter. She has CHARGE. She's 1 year old. Due to a severe infection at the time in hospital, they took out almost her entire large bowel. After that, we often had to change Emma's diaper 16 times by lunchtime. Ever since she's been eating mushy food, pureed food, we don't have to change her diaper quite as often. Stool is no longer as liquid. Now, would it be fair to say that it's not really a disadvantage for her not to have a large bowel, also in respect to constipation, or could this turn into a big problem for whatever reason?
That is very interesting. I haven't heard of that happening. So now, I presumably her bowel's been joined up. She's not got a colostomy. I would think it's joined up now. Again, my limited knowledge of how one functions without a large bowel. What does the large bowel do? Well, it certainly produces lots of problems in CHARGE syndrome as far as a constipation point of view. It's an organ system that is there really to collect the food that's been absorbed. So your daughter's going to be digesting, absorbing, and it just makes you think. It makes me think as a researcher if a lot of the problems with the gut is also very much at that bottom end, that you've got constipation. And as a general pediatrician, I often say treat the constipation, and then a lot of the other things actually settle down. So I think the large bowel, I would direct you to, presumably you had you should have a GI doctor, because the gastroenterologists are experts in that. So a lot of a lot of individuals with CHARGE syndrome do not have GI doctors. So you need a gastroenterologist. The only thing I do know is that the large bowel pulls the water out as well. So it tries to, you want to hydrate well, as in many conditions. The only thing I think you're running into is that because you haven't, the large bowel is like a bit of a cork, a little bit of a stopper. It's sort of, it stops the food from just traveling out and pouring out. So the only thing is what you're pouring in the top end is it going to pour out the bottom end? So is there going to be chronic diarrhea or chronic problems with loose stool? Conditions where large bowel has been taken away are things like a colitis. So I would direct you to the literature on that. Colitis usually happens, so this is ulcerative colitis. It usually happens in older people, not this young. So I think the literature, again, I can look up the literature for you. What is the literature on losing your large bowel when you're younger? Probably there is some literature on it. I'm happy to do that later and let you know what I find. But I would say the biggest problem will probably be chronic diarrhea and chronic water loss.
Kim, die gleiche Familie.
Kim, the same question, same family rather, has a question. Second question. Other than the removed large bowel, Emma does not have any obvious abdominal problems. Can we assume that this will remain the case, or are there any special exams that we should have done? If so, which ones?
So again, I would say make sure you're still in touch with a GI doctor to follow. I think that's important. I think with CHARGE syndrome, you never know what's going to be down the road, and I think you'll have a lot of the parents laughing about that as they sit there listening to this. Is never say never. it sounds like you don't have to worry about constipation for one thing, but there may be what you've heard me present today, the microbiome and especially if your daughter had an infection, I expect she was given lots and lots of antibiotics, lots of drugs, lots of IV stuff. That will affect the bowel as well. You may want to join our study to look at the microbiome, because we could look at your little one's microbiome, perhaps with a sibling or a parent. I forgot to say that. We don't mind a parent. We're looking at somebody who's eating the same environmental food, somebody who's sort of, even if you're eating different foods, you're in the same environment. So that might be something I could help you with. We will be giving out individual results. You can do that in research because that's your results essentially. If you've got somebody there that can look at the microbiome for you, brilliant. You want to keep in touch with professionals. This is a very not a common condition anyway. Charge is not common anyway. So it's like you've got Charge syndrome and a uncommon condition in Charge syndrome together. So close follow up. Very important, I would say. GI, maybe even an immunologist. We tend not to even follow up. The gut is full of protection with the immune system. But I would certainly be very happy to follow with you by email and stuff like that as well.
Kim, eine weitere deutsche
Kim,
Frage.
another question, a German one. My son is 12 years old. All he will eat is pureed food, pudding or baby food, and he gets Movicol, Movicol, every day to improve his digestion. There are phases where he will refuse to eat any proper food or real food, where all he wants to eat is pudding for days. Could that have to do with his digestion?
So there's often a number of things feeding into that. We know that with Charge syndrome, lumps and pieces and trying to work on those can be very challenging. If you think of the mouth and the tongue and the swallowing being controlled by cranial nerves, it may be that even looking with a speech language pathologist, how your son is manipulating things to it's not uncommon to have to be stuck at this stage of eating, and I presume that there may be no tube or is a tube or something like that. Some people are getting the tubes out quite late in life around this time, but all they're eating, because they've not been used to a lot of different textures and lumps and things like that they, and then you get stuck on liking one thing. So again, we know that there is a if we look at the autism population, they get stuck on one food. And why do they get stuck on that? They have some significant gut and GI issues as well. But I think the important thing I would say is work with a dietitian, make sure he's getting all the vitamins and micronutrients he needs. He might need those in a different format. He might need those added. So you don't want to be lacking in for instance, iron. That would be one basic one, but there's lots of the other, zinc and things like that. So I'd be very, very careful that he's getting enough of all the other things. That would be one of my worries. As he becomes more either wanting to or looks at other people wanting to, he may well try more things. But it's not uncommon to be stuck on a pureed, and then you just get stuck. But there is often keep trying with OT, speech language pathologist. He might be somebody that needs help with stimulation therapy to help with swallowing and it's more the chewing actually. So it's a problem, and it's a common problem with charge syndrome, with individuals with charge syndrome. It's common. So there might be some of your colleagues on there that have some other ideas, but you've really got to keep experimenting, keep trying, and they do get stuck on. For instance, as a pediatrician, I have many a mother that comes to me not with charge. They'll only have milk. They won't have anything else. So there's a degree of behavioral there. You know, it's much easier to just eat that and have that, and I like that taste. And we know that taste and smell is odd in charge as well. So just keep trying and keep experimenting.
Eine weitere deutsche Frage.
Another question asked in German. My daughter is 1 year old. She has massive gastrointestinal problems and extreme reflux. Larynx and mucous membranes have already been harmed. She gets jejunal nutrition and still often vomits, bile, amongst other things, and we're wondering whether fundoplication might help. What do you think about that? Or is there a specific type of tube feeding that could be used? It's not possible for her to eat on her own currently. She is permanently on antibiotics because she constantly has bronchial infections, and to protect her darm, she also is being treated.
That's hard. That's very hard and very, very worrying. And I expect there's a number of families that are nodding their heads and have been through. I mean, the one thing to know that with growth and with improvement, with motility, with standing, moving, gravity really helps. So it's. I often say. The GI problems are so much worse when you're lying on your back and you're not sitting up, you're not moving around. So the gravity's not on your side then. The fundoplication, people have gone back and forth with where the fundoplication. I think now we know that there could be anatomical, like the stomach could be smaller. I do think motility agents are important to think about. You may well have tried things like metoclopramide and things like that, but we used to use cisapride, which now got taken off the market, which is a shame. That was one of the best drugs for motility. There are some new ones coming out. So again, working with your GI specialist and making sure that you've got the best GI consultant working with you, or even reaching out for another expert opinion. What else could help the motility? Fundoplication is like a stopper at the upper end of the where the esophagus joins to the stomach. The trouble is with that, it tends to break down. It tends to get done a second time. It tends to not sort the problem out, and then you've had surgery, which later on could cause adhesions and things like that. So there's been a move away from it. It's not the be-all and end-all, but when you've got this amount of severe reflux and problems, I would say that looking at the pros and cons of fundoplication, it may be worth thinking about. I think with the anatomy and the motility issues, again, I think we could be thinking out of the box, looking for vagal pacers, which again a little stimulator that gets put into the neck. It doesn't need to be implanted into the gut. I'd be very interested if I'm going to get my student looking. I know there's at least 2 people I know that have used those, but in older life, not in this young a life. I think, the antibiotics is a problem because you're forever, you're forever altering again your microbiome with the antibiotics. So, trying to protect the gut with probiotics, prebiotics, and things like that. Very, very hard problem. One thing I would say is working with a physiotherapist, working with of course, speech and OT, but trying to do more upright feeding, upright positioning, making sure they're not she's not bent over, but it's all about using the gravity, and that's probably doesn't get as much good press as other things as it should do. So trying not to put down to flat afterwards. You're probably doing all of these things, but I think thinking about positioning and gravity being an important part of this. And I think I would be, if I was your doctor, thinking about perhaps looking into a fundoplication, but maybe you want to look at vagal paces as well.
I have two German questions, and then we have one that was asked in English by Peter. So why don't I read out the two German questions, so one after the other. Now, in CHARGE, do you have a higher risk of developing histamine intolerance?
I do not know the answer to that question. It's always wonderful. I get a question that I do not know the answer to. I know that that's can happen in the general population, so it's I have not heard about that.
Next question. Our son Erich is 7 years old, and he has a major problem with constipation. For almost 2 years now, we've been using Movicol, 25 grams per day, and he has a lot of migraines, and he loves eating sweet food, and he gets too fat at night. What could we change?
So your Movicol is remind me, Claudia, it's similar to the PEG, is that right? The Movicol is or is it more like the Senecot? Is it a bit of both? Yeah. Let me just
Das
look.
kann ich dir leider nicht. Das kann ich dir leider nicht.
Unfortunately, I can't tell you off the top of my head. I think Julia could have told you, but I can't.
Let me just check. Yeah, okay. So it's the same as PEG. It's a stool softener. It pulls. Movicol is one of the drugs. Is an Osmo? Okay, yeah. It's the same as PEG. It's the same as Restoralax, Movicol. Some of the drug names don't translate. So to treat constipation where it's a chronic problem, there's some very, and I'm working with a family in the States with this at the moment, you need to do a clean out. There's no way you could just keep pouring in Movicol and watching the results, which is the same result, still constipation. So a clean out can either be done with many doses over a weekend, over 3 days. Sometimes we use something called Pico-Salax without salts. Pico is P-I-C-O. Salax is S-A-L-I-X, I think. Pico-Salax is actually a sachet that you can use morning and evening. It does a clean out. It's actually where you would find that in the German literature is probably when bowel preparations. When you go in for a colonoscopy or a scope, they ask you to use a bowel clean out formula. Sometimes it has or hasn't got salt. So we use something like Pico-Salax or regular Movicol in the day. Usually Movicol comes in, I think we do PEG, it comes in 17 grams, capful. And if you're 7 years old, you need 7 of those in the day. Or if you're 12 years old, 12 seems a lot to me, but you need many doses in the day. So you're doing what's called a clean out. Then you're starting with somewhat an empty bowel, and then you would then go to your 25 grams a day. But you also need, I would suggest, a stimulant. This is a softener. This pulls water in. you also need something to do the motility, to push the bowel along. We use Senecot. There's other things that are German equivalents, but I think Sena is the natural product for, again, it gets a bad press, but I use it all the time, and I use it both together with the Movicol and Sena together, usually reasonably high doses of that as well, to push along the bowel. And then it's a chronic problem. Again, think of it more as a motility problem rather than this regular constipation problem. You could do massage. Once you start to get things working, you want to try, and that bowel is now big and it has pockets inside. So sometimes you need what I call a mini clean out every month, 6 weeks or something like that, so that you can you wanted to try and shrink that bowel that is now very highly distended because of the constipation, and you want to try and shrink it back down. That's your basic 101 constipation. I do that in clinic with my regular kiddos as well, but it's much harder with charge, and all your parents will tell you it's a chronic problem. One of the important things is when you've got the 1-2 year olds is to not run into that problem, is to get on top of it very quickly. But you need often more of the medication than you would normally use in an adult, or even we use quite a lot of, like, the capfuls of pegs. It could be 2 or 3 a day, and Senecot as well. So don't be afraid of using more, but you need clean out, mini clean outs as well. Again, a good gastroenterologist could take you through that. Even surgeons tend to work on good bowel. Some of the GI surgeons are better at doing this than we are, actually. I was talking to one of my surgeons the other day, and he would be inclined to give regular little enemas as well. I don't like enemas myself. We had a discussion about that, but he would do more the irrigation ones regularly, as well as other things, just to keep the bowel clear. Big problem, though, a very big problem.
Kim, wir haben eine Frage.
Kim, we've got another question in English, which is quite long. Do you want to read it out yourself? It's from Peter in the Netherlands. It's the 5th or 6th from the bottom. Peter, there he is. It starts, "Dear Mrs. Blake, interesting topic."
Dear Mrs. Blake, interesting topic you gave us. Thank you very much. I myself also have charge. So Peter actually has charge, and the intestinal processing problem are also recognizable to me, especially during puberty. I had the most trouble with it because of stress and school. Yes, Peter, very interesting. In addition, I drank way too much milk a day. Very good, very good. It's dairy is evil. I'm sorry, the milk people. Dairy is definitely evil. I also wondered whether the hormone processing play a role in what happens in the gut. The brain and the digestive tract influence each other, don't they? Absolutely. The brain, the GI tract feeds information to the brain. It's actually, that's the way the information, it goes both ways. But you think the brain controls everything, the GI tract. Think of the GI tract when you're stressed, when you're doing an exam, when you're I ran to the toilet twice before I gave this presentation. So you've got a lot of things going on with and anxiety, we know, is very, very, very common in charge syndrome. And it's more prevalent than I will have arguments with Tim about that, because he likes to stay away from these labels of autism, anxiety and things. But I call it autistic features, like only wanting puree food. I call it anxiety when, we're all a little bit anxious, but in charge syndrome, I think the anxiety can be driven from the gut as well, the gut's feelings. They do. Lately, my gut has been fine because I watch what I eat and don't eat fast food. Oh, brilliant. I mean, this is all my regular pediatric. It's so great talking to somebody who gets it, or ready meals, terrible stuff. Terrible foods. Yeah, terrible. It's actually like nuclear medicine to the gut. It's nuclear, not medicine. Medicine's the wrong nuclear. Yes, they're you're bombing your gut with things like that. That also helps. So it just, what you put in your top end is eating good food, that lower FODMAPs, that low dairy, good dairy, not bad dairy. And the comparison with Dutch and American food. When I'm in America, my gut, my gut gets into a fight about that. Yes. As far as food is concerned, how is that possible? No. Very possible. I mean, your gut is not. All of our guts. Think of going on holiday when you stop eating your fruit and vegetables and your regular things that you're used to. Broccoli is not available on a holiday. You end up with more constipation, more gut ache, more problems because you're eating all of that. So looking at a good dietitian, I do a 3-day diary with a lot of my patients, looking at what they're eating. You'd be amazed. All of a sudden it's, what do you have? I have a waffle with this on top, with that. And all of a sudden you say, well, where's fruit? Where's vegetables? Where's good protein? Where's dairy is harmful. So there's a lot of things that you can do to manipulate your gut by what you're eating. And I would say your anxiety is so working on behavioral ways of helping anxiety, yoga, meditation, mindfulness, exercise. I would push exercise for all of this. We went through exercise with the pot stuff, but your ways to even exercise your 1-year-old can help the gut. So looking at people that can promote that with you. But yes, I think all of what you've said there, Peter, is correct.
Kim, eine Frage von Christian.
Kim, there's a question from Christian seated next to me. He says, I have a lack of vitamin 3D. He is given 1,000 units. You said you can easily make that 2,000. Should he increase the dosage or rather talk to the endocrinologist?
I would say increase the dosage, Christian. To also the levels need to be checked again. Your bone. You might need to do a bone mineral density study to see how your bones are doing, because you may need something more than just vitamin D. You may need some other helpful medications that's going to help your bone health. So yes, I would look more at your bone health and see and look at the bones themselves as well.
He's just telling me he's sitting next to me and he's treated by an endocrinologist and he's given testosterone and his bone density has been examined and it's within the norm.
Oh, excellent. So that's all very good. And so you're looking at a number. Again, you can talk to your endocrinologist, but now, I mean, funnily enough, we all started off with 400 units. We've now all gone up to 1,000, and there's certainly, to protect bones in people that have got problems with their bones, 2,000 isn't too much. But I would check with your doctors as well to make sure that there's no contraindication.
Eine weitere deutsche Frage.
There's another question in German. It says, our 4-year-old daughter has trouble controlling her stool, passing stool. It's 4 times a day, small quantities into the diapers, or on another day, an extreme amount at one time. She moves around a lot, playing with her siblings. Can we help her bowel movements, taking her to the potty? How can we support her?
So she's passing a lot of stool frequently. You can still be constipated with passing little bits like rabbit stools. So sometimes it's looking again at the diet, looking at whether that stool is sort of building up inside. You don't need to do x-rays or anything like that. It may be little bits coming out that is not sort of again bolusing up like you saw from my presentation. So you're just getting the dribs and the drabs coming out. Sometimes you can do well with looking at a stool promoter, like so good lot of water intake. You might want to soften the stool if it is hard and rabbity. We say in the constipation world, anything that rolls is bad. So if it's a stool that comes out and it's a long sausage shape and it rolls, or it's little pellets in it rolls, that's still constipation, even if it might be happening 3 or 4 times a day. Behavioral training for potty training, a lot of it is watching other people, being secure. A lot of kids with CHARGE syndrome are put on a potty or on a toilet where they don't have good balance. Their balance is in, so making it very that there's somewhere for their arms, somewhere for their feet, so they're not tipping and toppling. So balance comes in. So a lot of things. Again, I work with OT. Physiotherapy for things like that, looking at seating, looking at positioning, making it fun, making it because that's a behavioral thing that can take a lot of time. Also, the feeling down there may not be completely normal. We know that. So it sometimes means going at certain times in the day to trying to push out. Again, the pushing out medicines like Senecot is very helpful, but waiting for them to have the feeling may not work. So you may need to put the feeling in there for them, which is called toileting after meals, after breakfast, lunch and dinner, or having certain times of the day to go and try with the pushing and everything, because that's where the training comes in. I hope that makes some sense.
Thank you. Then there's another slightly lengthy question asked by Anja. Her son is 6 years old. Shortly after birth, he was operated on at the aortic arch, but not in the breast region, but from the back. The intervention was from the back through the shoulder blade. The vagus nerve was injured. It was silent since then. His vocal cords and larynx were paralyzed, and because of other paralyses, no further examinations were done. The paralysis got better over the months. Then 2 years ago, he had a intestinal invagination and is now suffering from very bad constipation. 3 weeks ago, he had to vomit, and within minutes, he felt very poorly, got tired, had severe pain, had to lay down. And all that went on for a few days. He now receives Movicol twice a day, and we had 2 clear-outs before that. At the moment, he's doing fine. My question, can all of this be an effect, a consequence of the paralysis, or is it a different problem?
It sounds like the vagal nerve problem settled because the palsy, because the vocal cords came back. So it may have been that the actual nerve wasn't completely cut, or it was injured and it repaired, which often can happen. As you've heard with a lot of the other parents on the chats and what I've been presenting, you've got a pair of vagal nerves. One can work well, the other one may not work well. Both of them may not be working very well at all. It's a very long nerve that goes all the way down to the large bowel, which is where you get the constipation. It is probably not related to the paralysis, what happened at the beginning. This is very much CHARGE syndrome. The vagus nerve, the motility is not working properly. I'm glad to hear you had the clean outs, and you should continue with those, what I call mini clean outs, if you run into problems, so you don't run into problems. The regular Movicol, I'd probably, as a physician, I would add Senecot or a stimulant to that, something that pushes the stool out. I do know, though, I was talking to Nancy Hartshorn, whose son now is Jacob. I followed Jacob's story. I think he gets called Jake by his dad. He's the same age as my eldest son, 32, 33. And he was taken to hospital recently. And I don't want you all to get very sort of like oh my God, but he had a twist in his bowel. They needed to operate because it wouldn't untwist on its own. He's had it happen 3 or 4 times where he's just settled with IV fluids or an NG tube, and then his bowel settled. This time they had to untwist it. They noticed he had a small stomach, lots of adhesions because of post surgeries when he was little. He had a couple of fundoplications. He had a couple of G tubes put in. He had adhesions under the liver, I think the liver to the stomach, which the surgeon didn't want to cut because she was worried about more adhesions. But she said the bowel was all twisted around. But the interesting thing was the colon wasn't attached to the right place. So there was anatomical variations. We've always said that Jacob's had abdominal migraine, and probably he has as well, but he has had this abnormal anatomy of the bowel. So rest and stopping the bowel doing its digestive things can help with some of this stuff, can let the bowel settle down. What the surgeon did was pull all the bowel out and then put it all back in the right place. It's like making a puzzle again in the right place. But I think the long and the short is that treating the constipation, making sure that there's good bowel movements, making sure there's a softener, which is your Movicol, as well as Senna, which is your pusher outer, is probably important with individuals with CHARGE syndrome, and being very watchful that the bowel can be abnormal. It can be anatomically misplaced. So he is the 4th person I've heard about this, and I'm looking for the stories to produce a little paper that will characterize this. Adults that are going into hospital with acute bowel problems because the bowel is twisting. So there is problems ongoing, and I think it means that it's important to have a good GI specialist and to take the bowel issues seriously.
Kim,
we'd allow 3 more questions and then close it. The next one is asked by Steffi. Her daughter is 13 years old. Her mobility is limited. She's laying down a lot. She walks when held at the hand. She only eats pureed food, takes Movicol each day and 1 liter water by injection. They've been to the hospital a lot because she suffered from severe constipations. She vomited the pureed food, and in that condition she doesn't accept the intake of any other food or liquid. Gastroenterologist said that the food is kind of stuck in the gut, in the bowel, and she goes on to say since we've been giving her Movicol each day, her condition has improved, but there's still worsenings of the condition. We do a lot of massages. Her question is, do we simply have to live with it, or is there anything we can still improve?
Very common question. Poor Stephanie, I would say, because she's limited with her mobility. Again, she hasn't got gravity working with her. I would say looking at top to bottom, if you can get her more upright, more working, is there any way to she's not able to do it independently, but is there any way to help her be more upright? I know she probably doesn't want to be because she probably doesn't like the feeling of it as well, but even moving in small amounts, even from sitting to knees to standing, but some form of helping her with the upright positioning. I think it sounds like the Movicol has worked. You may need even more of it. You may need to definitely add a stimulant like a Senocot or something like that. Do it carefully, small amounts, and then increase. I would say that's often, you don't want to be pouring in a lot and then finding it's not working. The Senocot comes in a liquid as well as a tablet, and it comes in a chewable form for people that can chew, which is like an X-Lax. Oh my goodness. I think that it will be small changes over time. I think those are the key sort of things I would suggest, and then working with your doctors even to look at the charge checklist, there might be some things in there that you can say, hey, why didn't we think of that? If I was looking after Stephanie, I'd definitely go through the charge checklist as well.
Eine Frage zu einem
The
Stillkind.
next question, a child that's still being nursed, 15 months old. She only gets breast milk. She feeds well at the breast, no suction or swallowing problems. But as soon as you offer her food into the mouth, she rejects it. And the physicians say the nutrients in the milk are no longer sufficient. Is that correct? She needs to be bottle fed with additional food, else she would need to be tube fed. She's not undernourished, but she doesn't allow anything in her mouth. What can we do?
So with breastfed babies, my feeling is they just need some vitamin D. They get a lot in the breast milk. I'm very pro breastfeeding. If you're happy breastfeeding, continue to breastfeed. I'd speak to a different dietitian. No, I think certainly the feeding is an issue, and the swallowing, you need to work with your, again, OT, speech language pathologist, looking at maybe there's actually stimulation that you can do. She may not be, she's got a good suck and a good swallow. She knows what to do. So it's much, much, much nicer to keep breastfeeding. So there could be a behavioral component there. We get a lot of babies that don't want to or can't tolerate regular food, even pureed food. I think you need to start by offering a little bit, probably even working on sippy cup, I would continue to breastfeed, make sure there's vitamin D there. Formula fed, and those formulas aren't pre-digested and they can cause a lot of problems in themselves. She's growing and doing well. I think you're on the right track. Go with your maternal instinct, work with OT speech, and see if you can help with even starting on things like perhaps express breast milk in a sippy cup. Often babies that are like this don't like bottles very much at all. They go to sippy cup, working with the spoon, working on introducing even the spoon for play, taste of nice tasting things. Maybe make them savory. Beans and chicken are good, but I think you're doing fine.
Eine ganz letzte, ganz kurze Frage.
And a very final and a very brief question, again about vitamin D. If one hasn't taken it previously, how to start? Going in with 1,000 as a doses? The girl or woman is already 4 years old.
Yep. 1,000 is great, yes, and you can take it in lots of different ways. There's small dissolvable gummies. It comes in liquid. There's lots of different ways of getting vitamin D. Go for 1,000, and even 2. I would do that. Yes.
Vielen Dank, Kim.
Thank you so much, Kim. I close it here, and we'd take a break here now in our studio. To you, Kim, once again, thank you very much. It worked excellently. Thank you for being there for us, for taking the time, for answering all the great many questions. And I'll be happy to pass questions on as they come in, or also provide your email address if families want to contact you directly. And with that, many, many warm greetings to Canada, and maybe, hopefully, we'll see each other next year. Let's see. We'll keep our fingers crossed. Thank you, Kim.
Thank you, everybody. It's been wonderful. Well done, Claudia and team and everybody there. And you've done an amazing job. I mean, you've got me organized here. I'm always very anxious of doing. So sad I can't be there with you and answer your questions after the presentation. But if you want to convert those into English language, I've got students that I'm working with. They can help me. I'm not a great typer, but I can dictate to them. I can get them onto that, and we can try and get more of your questions answered. And with the ideas I've given you and some things that we've discussed today, I'm happy to do some follow up as well. So yeah. To my email or to Michaela's email. Michaela may answer them better than me. You could go with her first, and then she'll gather them all up. Maybe that's actually a really good way of doing it, because she's working with me now through the summer. You had her email there, but no, I'd be very, very, very happy to. Did you record the presentation, Claudia, at all? Did you have recording?
Yeah.
Yes, it was
Great.
recorded.
So again, you can if you've got it in English, we can pop it on the website, or in German on the website. I'm happy to put the presentation up as a. I think it was a good presentation. I think it covered a lot of things. The questions were great as well. Enjoy your
Ja, es wird beides geben, Kim.
There'll
Deutsch
be
und
both
Englisch.
versions, actually, Kim. We'll have a German and English version of the presentation on the website at some stage. It'll take a while, but we'll have it in both languages. So once again, thank you so much. Bye-bye, Kim. All the best.
Soon. Okay.
Bye-bye.
Bye.